We're going to have Dr. Meisner, who's going to speak next. He's a pediatric cardiologist from the University of Michigan, and he's going to talk to us about propionic acidemia and how it affects the heart.
All right, let's see if I can get this to work. Forward. Perfect. Goes back. Well, thank you for the opportunity to talk to you today. I want to get to kind of follow up on Dr. Amus's talk and try to understand. Speak louder. Perfect. And perfect. That's much better. All right. So I wanted to follow up on Dr. Amus's talk and kind of really understand some of the mechanisms behind the cardiomyopathy that it develops in propionic acidemia and how that factors into both how we follow up the heart function, follow up the electrical function, and potentially how we think about treatments to treat this. So I don't have any financial disclosures, and I want to acknowledge all the work that the Propionic Acidemia Foundation and the Community Health Clinic here does for kind of advancing the treatment of propionic acidemia and the care of metabolic disease in the region. And what I'll structure the talk to kind of first kind of talk about how the primary involvement of propionic acidemia is in the heart, how we assess that, and then kind of delve into some of the potential explanations for why propionic acidemia affects the heart and how that factors into our treatment decisions. So first, as Dr. Amusa led to, there's two different components for kind of the heart disease involvement in PA that I want to separate out a little bit. One is more of the heart muscle function, which is termed cardiomyopathy. Cardio, heart, myo is muscle, and pathy is disease. And then the more of the electrical aspect, which is the arrhythmia and prolonged QT. Both of them can help provide some insights in terms of where PA is affecting the heart and potentially how to manage and treat it. So to focus first on the cardiomyopathy aspect, the point of the heart muscle is to take in blood from the rest of the body after it's consumed its nutrients, after it's consumed oxygen, push it out to the lungs, get reoxygenated, and then resupply the body with that oxygenated blood with more nutrients so they are able to help do the things they need to do. And it has a marked capacity to be able to adapt to whatever the body is asking it in a normal, healthy heart. So for the cardiomyopathy that's present in propionic acidemia, this is primarily a dilated cardiomyopathy, which is the heart gets bigger and gets a little bit less, has less capacity to squeeze and pump out blood. So when you're asking it to do more, like going upstairs, doing exercise, kind of increasing daily activity, it just doesn't have the capacity anymore to meet what the body is asking it to do. And so the symptoms we'll wind up seeing are things that go along with that, which is being more tired in general, having less kind of activity tolerance. So getting more short of breath, getting more winded when climbing upstairs or kind of other activities like daily living. The other aspect is the heart muscle itself gets a little bit stiffer and requires a little bit more higher kind of blood pressure to help fill it. And that can cause kind of some leaking in the tissues downstream. So that pressure is a little bit higher in the blood vessels downstream in like your legs, in the belly, that causes fluid to leak out. And you can have some accumulation of fluid, which is swelling or what we term as edema. And the other aspect you will wind up seeing, maybe a little bit more so in kind of like younger children, if that happens, is as you're eating, you're also asking the body to do a lot of work to help process that food. And if the heart doesn't have the capacity to meet that ask, patients can start to feel some abdominal pain or nausea, just don't have that same sort of appetite. So those are the kind of key symptoms we think about related to the heart muscle dysfunction and signs of heart failure. So how do we measure this? Kind of the workhorse of looking at the function of the heart. This is true in both propionic acidemia as well as kind of the broad spectrum of cardiomyopathies is really the echocardiogram. And that's kind of using ultrasound to assess what is the size, what is the function of the heart muscle, and provides a lot of nice dynamic information. So as you can see here in kind of the upper right corner, you can see the heart muscle itself as it's kind of squeezed, and you can actually kind of get a good idea of how much that blood is ejecting. And so the quantitative things that we look at from that are like the ejection fraction. So what is the volume of blood at each individual heartbeat that the heart is able to squeeze out? Is it in the normal range? Is it in the abnormal range? Is it kind of somewhere in the middle? And you can look at the size and shape of it to see, is it kind of changing kind of an abnormal size? Is it getting bigger? Are the walls getting thinner? Is it kind of taking a more of a like rounded appearance? And you can start to piece apart, are there some subtle signs of heart muscle dysfunction by using some other advanced techniques related to echocardiogram, like looking at things like myocardial strain or kind of like the relaxation capacity of the heart muscle itself. And so those are kind of the core things we look at when we're trying to assess what is the heart function in a given person. Rarely in more advanced disease, the other thing we can look at too is in cardiac MRI, which gives us a little bit more detailed picture of kind of the 3D structure and function, but gives us really unique advantages of kind of looking at the tissue characterization. Is there any sort of early signs of like heart muscle injury and scar formation within the heart? But that tends to be more rarely used in more advanced cases. Primarily because it requires a lot of kind of tertiary facilities, has a lot of costs, potentially needs sedation. It's a much longer procedure. So as Dr. Amus alluded to, like we've known about cardiomyopathy for 30 years now, and it's really been difficult to kind of assess like who is going to be affected. And that has a lot to do with the fact that PA is a rare disease. There's just not a lot of people. There's not a lot of data. And so all the things we're talking about here kind of throughout the day is we're kind of basing it on a little bit more limited findings and trying to piece apart through different case studies, different patient presentations, and some limited like in vitro cell work or mouse work, and really trying to tie things together. It doesn't have the advantage of having millions or thousands upon thousands of patients to help detail things down and figure out who exactly is going to be affected. What are the optimal treatments for PA? But of the stuff, like over that course of time, we are building an advance of knowledge about who is potentially affected. So with cardiomyopathy, it's highly variable, but there's a large portion of of patients that are affected. So like 25 to 40%, which is a significant portion of people. It can happen at kind of any time in life from age 2 up to adolescence, sometimes even presenting adulthood without any other previous features. So there doesn't seem to be a clear tie between metabolic control and heart function. Although if you kind of look at the molecular mechanism of how it's happening in the heart muscle itself on the individual cell level, it would make sense that there should be some sort of correlation. So because of that variable time, like variable effect of who's going to be affected and not necessarily having clear markers of why a given person is affected, we need to have like serial surveillance because there is also evidence that it's a progressive disease over time. So if you're not affected as a 2-year-old, that doesn't mean you're not going to be affected as an adult. So one of the few studies that actually looked at prospectively, what is the function of heart over time? You can see that on the x-axis, that's age, and on the y-axis, that's saying the number of people that have normal heart function. That kind of decreases steadily over time. So it's a progressive disease, been looking at kind of the subtle features of heart muscle function. So having serial surveillance is very important to figure out who is going to be affected and when do you need to have more advanced therapy. So that's the heart muscle function and the cardiomyopathy. The second aspect is arrhythmia. And when I talk about arrhythmia, I'm really talking about kind of the electrical activity of the heart. So what the thing that guides when a heart beats is kind of an electrical signal. So if the top half of the heart in the atria, it starts this electrical signal, tells the top half of the heart to squish blood into the bottom half that's then able to pump it out to the body or into the lungs, has this little waypoint in the middle, and then the bottom half pushes that out to the rest of the body. And all of that is driven by kind of the electrical changes of salts in the actual heart muscle cells that guide that process. Has this very regimented process of certain salts coming into the cells, certain salts leaving the cells, and it's highly regulated. And the process of like the heart muscles contract, the cells contract, the hearts then have to relax and kind of re-normalize things before the next beat happens. So the key component that is one of the key things that's affected in propionic acidemia is kind of the repolarization of those heart muscle cells and kind of getting back to a normal state so it can beat again. So if you kind of follow the right-hand arrow, left-hand arrow, you can see like the signal from the top half of the heart is kind of a P wave. So the thing that we're looking at when you come in for a surveillance is kind of the electrical activity, which is an EKG. Top half of the heart beats, you get a little bit of electrical signal. The bottom half of the heart beats, which is a much larger volume muscle, so you get a little bit larger signal. And then that third wave, the T wave, is that heart kind of getting back to its normal state and having those salt ions flow back in and kind of set things up for the next beat. And the reason why that's a potential problem in PA is that repolarization phase, where the heart takes to how long it takes for it to get back to normal, we can measure as its interval as like a QT. We'll just term that it's going from like the start of the heart to when it's fully back to normal. That can start to get prolonged and a little bit slowed in people with PA. And that presents a risk where if part of the heart muscle is not fully back to normal, people, like everybody has these random extra beats that happen on a given database basis. If the heart is not fully back to normal and an extra beat happens, it can cause this abnormality where the electrical activity kind of goes around a loop and the bottom half of the heart starts beating independently, really fast and really not coordinated. And that can create a life-threatening situation where you just don't have a normal like function of how the heart muscle is beating and moving. And so that's one common way for a heart-related death. And it's kind of serious and life-threatening situation in patients with PA. So what do we know about arrhythmia and propionic acidemia and kind of the heart and the QT prolongation is that it is also pretty variable across people with PA. Some people get it, but it tends to be maybe a little bit more common in people than the cardiomyopathy aspect. And it also tends to increase over time. We're again very limited by the data that we have in that it's really based on a few kind of case studies and series that have kind of come through over the course of time. But we can see that the ability for the heart muscle to kind of get back to our normal state, that QT interval can kind of increase over time. And that increase over time, if you can think of it, that delayed repolarization is kind of the risk for having abnormal heart rhythms. As it gets longer and longer, the risk gets higher and higher. And kind of tying those two things together, there is some overlap between QT prolongation and cardiomyopathy, but it's not really tight. So some people that will get cardiomyopathy may not have QT prolongation. Some people that get QT prolongation may not have cardiomyopathy, but there is a little bit of overlap between two things, which kind of leads back into how are they working together and why is PA causing these potential problems in the heart muscle? So from a arrhythmia standpoint, the key workhorse of like trying to figure out who is affected, do we need to think about certain management changes, is really driven by kind of assessing the electrical activity of the heart muscle. So kind of recollecting that information on EKG to assess what is the electrical activity, what is that interval, the QT interval, how is that changing over time, and is it kind of shifting outside of normal or is it staying in the normal range? And those that we start to see it kind of shift outside of normal, thinking about how do we best manage that and how do we do a little bit more deeper digging, like doing a prolonged EKGs like over the course of multiple days, which is what we would term like a Holter monitor, to see if there's any sort of other concerning abnormal or underlying rhythm abnormalities. So this kind of leads to the question of why does PA affect the heart muscle? So I'll have the caveat being that we don't have a definitive answer, but there's a fair amount of evidence out there, both from like patients that have propionic acidemia, cell studies, mouse studies, animal studies that are suggesting there's kind of like a core mechanism behind what is going on in propionic acidemia and how it affects the heart muscle. The first is looking at the toxins related to that build up because of the deficit in kind of the processing of propionyl CoA. So propionyl CoA can potentially have toxic effects within the cell, affecting oxidative stress and causing a lot of other stress and strains. It can shift other metabolism, other aspects within how the cell processes energy. It can start to, because of how it builds up in the cell, it can start causing a lot more stress on a cellular level that makes the machinery to help process energy and helps keep the cell nice and healthy start to have deficits. So we know in patient samples and in muscle, heart muscle, that some of the energy handling machinery starts to decrease, potentially related to an evidence based on like the oxidative stress that happens on the cellular level. And it kind of centers back around to, as Dr. Amus alluded to, how the cells process energy. And because of the break in that chain of the PCC enzyme, you don't have the same sort of substrates that are able to process energy in quite the same way. And that leads to this common deficit in terms of how the heart muscle processes energy and potentially how it's affecting that heart muscle cell. So why are we focused on the heart muscle, and why does it show up in particular in heart muscle versus any other cell type? A lot of it has to do with the fact that heart muscle is a really energy intense organ. It has to push against blood pressure, has to do a lot of work, 60 times, 120 times a minute. It's in your entire life. That takes a lot of energy. So it demands a lot of energy. And the most efficient way to give that heart muscle energy is through these energy intensive, like generation processes within the mitochondria, through the citric acid cycle and kind of fatty acid oxidation that are impaired in PA. So if we kind of look at kind of the energy inputs of fatty acids, amino acids as like energy sources, when they get funneled into the development of propionyl CoA, it's not able to be processed from that standpoint forward. So the buildup of the propionyl CoA itself can affect the energy handling machinery. But because of that loss and that chain of stepwise energy production, there's this massive loss of energy potential and ability to generate energy. If the heart is highly dependent on energy, it essentially gets sick and starts to function in a much less efficient manner. And then those downstream effects of kind of the toxic metabolite buildups further exacerbate that process, leading to this feed forward potential mechanism that leads to kind of the heart muscle dysfunction. And if you kind of look at the bigger picture of energy metabolism, that's actually a very common pathway in a lot of cardiomyopathy outside of propionic acidemia. So the common pathway of like, if there's a heart muscle problem in terms of its ability to it's contracting too strong or too weak, the key signature on a cell level is really loss of energy metabolism. Is that you get this shift from super energy efficient processes to very energy inefficient processes, whether that's in kind of the muscle component, whether it's in whether it's in a more direct mitochondrial function component. So if the mitochondria is the powerhouse of the cell, if some things are directly interfering with that process, you can get a very similar sort of change on an energy handling process that leads to heart muscle dysfunction. So there's a lot of overlap of the cardiomyopathy kind of cellular mechanisms that happen in PA, as that also happens in a lot of other cardiomyopathies. And then if we think about how does it potentially affect rhythm and why does it affect QT prolongation? There's also some component of that. We can look at the understanding of how the cells repolarize. So as Dr. Moose mentioned, is that you can have a QT prolongation in PA, but that's also present in a number of other disorders, in particular like long QT syndrome, which is much, much more common, has much larger number of patients, and it's a much more defined approach in terms of like management, in terms of potential therapies, treatment, monitoring, that has a lot of overlap. And we understand the actual mechanism of how salts move in the heart cells, how the electricity move in heart cells, and be able to use that understanding to really potentially back calculate and trying to understand what like propionic acidemia is doing. And have been studies that look at heart muscle cells taken from patients or derived from patients, and showing that the delay in repolarization, the QT prolongation that is seen in propionic acidemia seems to be related to some of the toxic metabolites that build up in propionic acidemia. So if you take the circulating metabolites from patient serum. So if you take the blood from a person with propionic acidemia and you apply that to the heart muscle cells in a dish, you can actually reproduce that QT prolongation, suggesting that it's not necessarily, there's some components which are intrinsic to the cell itself and some components which are kind of circulating in the body, and kind of the separation of those two components. So, and that can get to the question of the effect on the heart in propionic acidemia. There's kind of two different ways, and potentially not necessarily exclusive, but adding together, of how it can be affecting it. One is from kind of the systemic effects. So all the other aspects of what's happening in propionic acidemia that's circulating through the body, and those that are actually part of the heart muscle itself. So how do we start to assess that? Is you can kind of use the kind of experiments that happen in just general patient care. And one of the ones that is really informative is the concept of liver transplant and propionic acidemia. So if the liver is really is critical to the processing of amino acids and kind of the metabolism that generates propionyl-CoA, if you transplant the liver and you help stabilize the metabolic control, how does that affect the heart muscle? And there's some evidence that the cardiomyopathy that can be present in propionic acidemia actually is able to get somewhat reversed with liver transplant, suggesting that there's a component of like circulating metabolites, toxins that are kind of developing in the body that are feeding into heart muscle function. But that's not always true. So even after a liver transplant, there have been cases of cardiomyopathy redeveloping that may suggest that it's not just a circulating component. It could be actually intrinsic to the heart muscle, which is really important for kind of understanding what are our optimal approaches. What is the best way to treat the heart muscle function in propionic acidemia? So now let's kind of take that understanding and apply it to, what are we going to do about it? How are we going to treat the cardiomyopathy or prolonged QT in propionic acidemia? One is it's kind of this combination of different factors, combination of reactive oxygen species, combination of potentially toxic metabolites, and kind of energy production within the cardiomyocytes themselves. And it's both this combination of both kind of the circulating systemic factors and the effects on how the heart muscle itself is able to kind of produce energy. So when we're thinking about our next generation of therapies, like RNA therapy or gene therapy, we're trying to replace PCCA throughout the body. It really has a big implication of how is it expected to have a function or kind of handle in the heart. So some therapies are able to kind of directly integrate into the heart and kind of like help support the heart function. Certain therapies are more targeted to the other aspects in propionic acidemia. So if we don't necessarily target the heart, there may be some benefits, just like liver transplant on heart muscle function, but it doesn't necessarily preclude kind of the development of potentially the development of cardiomyopathy or kind of the arrhythmia aspects related to the heart for propionic acidemia, if you're not directly treating the heart muscle. And then if you kind of think about the mechanisms behind the prolonged QT in propionic acidemia, so kind of the more detailed studies that are suggesting that kind of circulating metabolites affect kind of the repolarization, kind of the normalization of electricity in the heart muscle cells. There's some evidence that it affects the same pathways that are affected in long QT syndrome, particularly long QT syndrome type 1. So we can potentially borrow some of the management guidelines, kind of borrow the thought process behind treating that type of disorder from a heart aspect as long QT syndrome, and the kind of universal overlap of kind of energy handling and abnormal metabolism and cardiomyopathy can also potentially be applied towards propionic acidemia with some exceptions. So we think about the management approaches in cardiomyopathy is I generally think about, if I see a patient with kind of the development of cardiomyopathy, I can use universal heart failure management approaches, it's related to how that heart muscle is able to process energy. So we want to make it have less demand. We don't want to make it consume as much energy. The best ways to do that are to kind of make it work less. So if you look, the heart itself is working by like pushing against blood pressure. If you use medications to help lower blood pressure, you're making it work less. If you use medication to help slow the heart rate, you're also going to make it work less. Those are kind of the fundamental principles of treating cardiomyopathy that seem to would apply in propionic acidemia. That doesn't guarantee they will work. And of the limited patients that develop severe cardiomyopathy, it seems to maybe have some benefit, but doesn't necessarily fully reverse things. And the disease can still, like this heart-related illness, can still advance despite these therapies. So yeah, so there's a kind of heart muscle kind of work function. There's some other medications that really can help treat kind of the development of scar formation or kind of fibrosis within the heart muscle itself because of the irritation and the extra work that it's having to do. And then if the heart muscle is getting really sick and it's having kind of this stiffness aspect where there's fluid accumulating, we can help pull off some of that fluid using diuretics as needed. The exception to kind of the typical approaches to heart failure management with propionic acidemia are that the more recently, with the recognition that it's really there's a lot of energy metabolism and kind of energy handling and cardiomyopathy kind of more broadly, has suggested there's certain medications that have ability to target that. One of those being a diabetes medication called SGLT2 inhibitors. You don't have to remember that component, but there are certain newer medications that kind of focus on trying to shift how that heart is processing energy that have been found to be really beneficial in a variety of cardiomyopathies. I don't think because of the reported side effects of causing acidosis or that are related to these therapies, that this should really be applied in PA. So kind of having a thoughtful process of how to take from current understanding of like cardiomyopathy treatments and applying that in this unique situation of propionic acidemia kind of takes a specialized knowledge and kind of consideration. So in terms of thinking about management of the arrhythmia aspect is because there's some overlap of how kind of the rhythm abnormality that we focus on in propionic acidemia, the long QT, the same sort of proteins that are involved in ion channels that are involved in long QT syndrome or have some sort of evidence showing up in propionic acidemia, we can borrow from some of those management. So one is following kind of the electrical activity closely on a regular basis. And if we start to see some abnormalities in the electrical activity, like having a longer QT, considering some of the medications that we use for other syndromes that cause that, like a long QT syndrome, like adding on a beta blocker to help minimize the risk for kind of abnormal heart rhythms, and doing a little bit more detailed assessment with a continuous EKG over multiple days, and that's a Holter monitor. And then avoiding drugs that would make things worse. So there are certain medications like antibiotics. There's kind of a broad list of different medications that can make that slowing of the heart kind of getting back to its normal rate and that QT interval much longer. And so being aware that if somebody has started to develop a prolonged QT, to really be hesitant and make sure that other providers know that that's the case so they can avoid these type of medications. And if there are certain, and if arrhythmias do start to develop because they can be life-threatening, have a discussion of does it make sense to have like a backup safety device in place to help get a heart back out of those abnormal rhythms and concerning rhythms by having essentially an internal defibrillator. That's a larger discussion that takes place in a more specialized center, but has that potential as an option of a kind of a saving or rescue therapy. So as a general summary, so thinking about the involvement of propionic acidemia in the heart muscle, it's really important to have like regular follow-up. It's really variable across an individual with propionic acidemia, whether they develop the rhythm aspects, whether they develop the heart muscle dysfunction aspects, and having serial monitoring, especially because it can slowly develop over time by EKG, by echocardiogram on a regular basis. Based on how PA works and potential mechanisms of how it's affecting the heart muscle, and the fact that it's potentially related to the circulating toxins and metabolites, as well as the energy handling. Well, we don't have clear data showing that targeting a specific pathway in metabolism really affects the heart muscle. Broadly, it makes sense to try to like maximize it as best as possible. Having good metabolic control, working with your dietitians, kind of using carnitine, using other mediators, it makes sense to help support heart function and trying to figure out how best to do that in the future. And that kind of gets to the point of we need to have more data. We need to have more studies, collaborations like through these education benefits, kind of having networks of clinicians, patients being involved, contributing data to improve our understanding of who is going to be affected and the best ways to treat those that are affected. And then in the meantime, pooling our knowledge from the treatment of other cardiomyopathy conditions and other arrhythmia conditions to help support and kind of improve the care from a heart aspect related to propionic acidemia. And so I'll pause here and give some time so we can go over and kind of have a little bit of discussion about any other questions related to it. Mhm. Yeah. So like the beta blockers themselves. So so to repeat the question, if you have a prolonged QT and you start on a beta blocker, does that actually change the QT interval? And that's not actually the case, which doesn't make a ton of intuitive sense. It's more of a protective factor of how to set up the heart so it's less at risk for developing the life-threatening arrhythmias. Sometimes the QT interval will shorten a little bit on beta blockers, but it's really a protective effect of the beta blockers on preventing kind of the ventricular arrhythmias that are really the life-threatening aspect from prolonged QT. So even though you're on it, you don't see a change, there's benefit from being on it. So what is that? The pancreas? So, so the question was, what does the pancreas do in the body? And that's a little bit different. So the pancreas is really important for like helping to break down food, and it provides a lot of enzymes that help process fats, process proteins, break things down when you're digesting food. So it's really important in terms of like maintaining good nutrition, which is kind of has potentially an indirect effect on the heart muscle, but it's not necessarily directly related between pancreas function and like heart function. Mhm. Mhm.
I just knew that because they like pancreas help break down food into protein. So I was wondering if that could be something to work on to keep healthy.
It is important to have all the organ systems work very well, but I can't directly answer that question. Okay, so the question was, what is the difference between arrhythmia and palpitations? So sometimes they do overlap. Palpitations are when you can feel your heart beating in an abnormal fashion. Oftentimes, that is from kind of the extra heartbeats that I was talking about that can just happen in a person. There's this weird spectrum of people that can feel every single abnormal heartbeat and those that don't. And that's why it's sometimes helpful to have more continuous monitoring to see to pick those up. But the real concern is like the palpitations, or if you're able to feel them and they're moving, you still have enough blood flow and enough like heart function, even though there's these extra abnormal heartbeats, to be able to keep moving and doing your normal sort of life. In the arrhythmia, what happens is the heart kind of goes around this like electrical circle much too fast, where it's not able to fill or like pump blood efficiently. And the ones that we're really concerned about is where it's beating so fast that you pass out because it doesn't have enough blood flow. It doesn't have enough blood flow to support flow to your brain. And that's more of the life-threatening aspect of it.